All right. Thank you very much. So I am going to talk, next slide, please. So today we're going to talk about what I call the big three going into the winter here. This is SARS-CoV-2, the virus that causes COVID, influenza, and RSV, respiratory syncytial virus. Next slide, please. So a little bit of a refresher. We all remember COVID. This is a
Can you make it
disease
any
caused by
bigger, Mike?
the
No?
virus
I'm not following
SARS-CoV-2.
with this.
Oh,
Just,
okay.
you could close down the transcript.
As you'll recall, after our vaccines, most of these symptoms, and you're going to see a pattern here with all these diseases, are very mild to moderate respiratory symptoms, that classic prodrome of fever, cough, little bit tired, achy, runny noses, and sore throats. Now, what's concerning is some of our older patients and those with comorbidities like high blood pressure, heart disease, diabetes, they're far more likely with COVID to develop more serious illnesses. And SARS-CoV-2 is in the family of the coronaviridae viruses. Next slide, please. Influenza. This is it's a little squint on this one. This is a viral respiratory infection as well. Influenza comes in two main types that we talk about, influenza A and influenza B. These are broken down so that we can discuss the specific types, and we'll get into this a little bit more in a minute, by the presence and type of hemagglutinin and neuraminidase that these have. So this is what leads to certain strains of influenza being called H5N1 or H1N1, which is swine flu, or H2N5 as examples. That's how we start to classify so we can talk about them, and that is about the proteins hemagglutinin and neuraminidase. Again, these symptoms are that classic runny nose, fever, sore throat, fatigue, 5 to 7 days of illness. RSV. I like medical history, and syncytial is actually a Greek term that means two cells joining together, coming from the Greek origin of syn, together, and ketos, cell. RSV, and this is my big point here on this slide, RSV is a leading cause of infant hospitalization in the United States. I'm going to pause and let that sink in. Of all the things that cause infants in our country to be hospitalized, the number one cause is RSV. This is a vaccine-preventable disease. Symptoms in adults and healthy older children are mild, cold-like in nature with that runny nose, sore throat. Are you seeing the pattern of how these all affect our bodies? Oh, wait, can you go back, please? Thanks. Now, what's concerning with RSV is while it strikes this kind of bimodal distribution of the really young infants and our older adults, they're starting to see more severe infections and hospitalizations in our older adult population as well. So this is why we're going to talk more about that vaccine here in a moment. Next slide, please. I wanted to briefly talk about the difference of virus versus bacteria, because there's a vast difference. They're like cheese and chalk when you compare the two. Viruses and bacteria are both microscopic, and they both cause infections in humans and animals. Bacteria are a single-celled organism that can live outside of bodies and outside of their host, and they can reproduce on their own. Viruses are non-living collections of just genetic material, just DNA or RNA, that needs a host, an animal or a human, to reproduce and replicate. We treat bacterial infections traditionally with antibiotics. Viral infections get antiviral medications and vaccine prevention. So this is a key point here. Vaccines aren't new technology in our world. They go back 300 plus years to Dr. Jenner. He was an English physician in 1796, and he noted that milkmaids who were milking cows and were previously infected with a very minor disease called cowpox were also immune to smallpox. So appropriately, he thought, well, maybe he could do something with this. And he took a little needle and he rubbed it on the sores of the milkmaids on their skin that had cowpox. He then injected that, stabbed them with that same needle, and noticed that the people he inoculated with the cowpox vaccine no longer got smallpox. They were immune because those two viruses are cousins. Much like monkeypox, mpox, another one we'll talk about here today. And because of this, the milkmaids, the cows, cowpox, The word vaccine is a Latin derivative from the word vaca, which is cow, also in Spanish. So I wanted to talk a little bit about virus species, strains, and variants, because this is going to be important when we talk about the types of vaccines and what they're covering. A viral species is the big class, the big group. Influenza, herpes virus, coronavirus, varicella that causes chickenpox. Those are the big umbrella categories. Strains are more specific underneath the species. So this is going to be your influenza H5N1 or H1N1. That's a different strain of the influenza virus. Now then we have variants. Variants are even smaller subgroups of that. So for example, coronavirus is the species. Coronavirus has several different strains. MERS, Middle Eastern Respiratory, SARS, we remember, and then SARS-CoV-2. Those are different strains. Now, subgroups within SARS-CoV-2 are the alpha, beta, delta, Omicron variants, flirt, that we're seeing now and talking so much about. And this is going to be important when we talk about what our vaccines cover. So why is this important? Viruses change and evolve rapidly. This is part of their genetic adaptation to continue to survive. These SARS-CoV-2 variants are great examples. Remember, it started off with the plain vanilla alpha. Then after a couple months, we had Omicron, Delta. And these changes are usually due to genetic mutations in the virus as they replicate within a host. So the more people that are getting infected, the more replications are occurring, the greater the chances for mutations and formation of a new variant that can evade our vaccines. Okay, next slide, please. So briefly, the type of vaccines that we want to focus on here today. Live virus. This is a weakened or stunned version of that virus. MMR, measles, mumps, rubella, varicella, and oral polio are classic examples of these. Then you have a killed virus. These can't make you sick. Inactivated polio, Hep A, and rabies are classic examples of those. Now we've got the mRNA viruses, vaccines. These go back, this technology, to the late 70s, early 80s. And you may know Pfizer and Moderna from the COVID vaccines. This is really cool technology in the fact that messenger RNA in the vaccine teaches our cells to produce the same type of protein that's found on the coronavirus. So it's basically parachuting in a bunch of teachers, training our immune system without using the actual virus itself. Okay? The last one, oh, that's all right. We can skip the last one. Go ahead into the next slide. We'll go ahead. Next slide, please. All right. So talking about the COVID vaccine. This season, 2024, is going to cover the JN1 lineage and the KP2 strain. This is the one that they suspect is going to do the most damage. This is the one that they suspect is doing the most circulation. All right. Now, if you see, looking at ages 5 through 65 and older, it's one dose regardless of prior vaccine status. This is moving towards a trend of that seasonal influenza virus, right? You get one, you're done. I wanted to draw attention for those with children or those that work with children. Ages 6 months to 4 years of age, if you're previously unvaccinated, we want to get 2 doses of Moderna or 3 doses of Pfizer into you. And hopefully using one of the 2024 strain this year so that we get that protection against that JN1 lineage. All right. Now you see the 65 and olders, remember that's a vulnerable group that the virus can cause morbidity and mortality in that age group. An additional updated vaccine following the 2023-24 dose. All right. Now, how good is this vaccine? People ask me this all the time. The vaccine efficacy showed 54% against symptomatic SARS-CoV-2. So 54% of the people who get vaccinated and get COVID, they don't have any symptoms at all. They don't even notice that they've got it. All right. But what's important to remember about this vaccine is it's going to keep you from dying. You may have vaccination and you may get a little sick with a day or two of runny nose, sore throat, but you're not going to the morgue. If you look down at that bottom, 57% reduction in mortality among those aged 70 to 79. 54% decrease in deaths in the 60 to 69-year-old group. and a 52% reduction in death in the 50 to 59-year-old age group. So again, I want to remind everybody that this vaccine, while you may have the vaccination, you may get sick. You've got about a chance of roughly, oh wait, can you go back please? If you could go back to there you go. You've got about a 54% chance of not having any symptoms at all, but you've got about a 57% chance of staying out of the morgue with this. All right, that's important. I see MS has a hand up and a question. Go ahead and shoot.
Hi, this is Mo, and I'm trying to fix my, okay.
Hey, Mo. Awesome. I didn't recognize the MS. Thank you. How you doing?
That's okay. I have a question about this because I want to say that the hold line at the Safeway pharmacy says if you're 65 or older and you haven't had it in 4 months, you should get a booster.
Yes.
Is that, and
Yes,
so that's
it.
And then what about the
That's
rest
it.
of just once a year?
Yeah, this is where we're going. We're going to once a year and getting that top up. And if you are fresh and never had it, you're looking at 4 months following the last dose, right? And the suspicion on this is that we want to have coverage. We want to get you at the beginning of winter, September-ish, and we're worried that come come December, January, that protection may wane a little bit. So we want to top you up again in January to carry you through February, March, and into April. That's the goal with that second dose.
So if we're 50-something years old, should we get, I'm asking for myself here, but but in general, I mean, are we, I don't know, is it arbitrary, the 65 number every 4 months and the rest of us once a year? It just seems a little strange.
The reason why is because if you look at those age groupings and those mortalities, this is a cutoff on age, okay? And if you see the reduction in mortality, the older you are, the greater you have a chance of dying from COVID.
Sure.
And we drew that line in the sand.
Okay.
Say, we want to start protecting this population and above with that double, right? The 64 and under are a one dose with this season's 2024-2025 vaccine to cover, and it's going to be an annual, likely, moving forward in the future.
And when does that come out?
A good question. We're all waiting. We're waiting because, as you know, in the media, we're seeing that COVID cases are ticking up. I suspect definitely by the end of the month. I have a high suspicion it's going to be in the next 7 to 10 days.
Oh, good.
The vaccines are ready and the vaccines are made. I think what we're looking at now, and this is just my hypothesis, is that we're looking at a supply chain issue of how to flow them physically on the trucks out. Okay.
Interesting.
But
okay.
it's going to come quickly. You know, it's tough rolling out a big vaccine of 50 million vaccines to 50 states. It's tough. And I suspect we're all going to have ours ready definitely by the end of the month, and likely.
Dr. McLaughlin,
yes,
this is Barb. Actually, I'm getting my vaccine today. So it is at the CVS in Sierra Vista. It started on Wednesday, so there is a supply currently. And then Evelyn asked if somebody has comorbidities, should they be getting a boost?
All right. Two issues. One, Barb, are you sure that you're not getting it because you're our health director and you get special treat? I'm just kidding.
No, because my
husband
husband got it on Wednesday.
Good.
And he didn't disclose
I'm thrilled to hear
anything.
that.
So the supply is here.
Good. I'm thrilled to hear that. It hasn't reached my local CVS up in Tucson yet, but that's good to know. Regarding the comorbidities and the booster, it's going to depend on what your comorbidities are, and that's a good conversation to have with your doctor, okay? It's going to take into a lot of individual considerations. Have you been previously vaccinated? When was your last vaccine? If you had your last one in 2019, if you're 67 years old and you were on oxygen, you've had a few heart disease issues, you may be a good candidate, yes. But that's a good question for your family doctor who's going to know what comorbidities you have and your last vaccine schedule, right? There's
So
no
will
one
they-
size fits all on that one.
So will they permit it? I get they being the whomever, the CVS's, the Safeways, the Walmarts, whoever the vaccine givers are. If your physician says, hey, I think you should get a second, and you're less than 65, well, is that permissible in terms of the vaccine distribution people?
That's a good question, and I can't comment on the policies, protocols, and procedures of individual CVS's. And I pick them arbitrarily, or Walgreens, or whatever. I can tell you that when I went to vaccinate my children a few years ago, there was resistance from that particular store that I went to. I went to another one around the corner, 3 miles up the road, and we were vaccinated, no problem.
Okay,
I
so
think
it's really
very
dependent. So there's not like
I would-
federal prohibition or anything
No.
like that.
And I would ask my doctor for a script. If my doc can't give the vaccine to me in the clinic, then I would say, hey, can you write me a script just so you've got that piece of paper to show to the pharmacist to say, hey, look, my doc's on board with this. He or she said, we're looking at a 2-dose regimen for me, or a single is fine. I
Okay.
think that would be very wise. All right.
Good to know. Thank you.
Good questions. Shifting gears into influenza. Currently this season, we're going to cover 3 strains. This is a trivalent vaccine, which is a change you may recall from previous influenza vaccines that had 4 strains protection. Some of us are a little confused by that. I've always been a more is better kind of a guy when it comes to protection. But the reason why is because a previous strain of influenza, the Yamagata strain, is just not really around in the world that much anymore. It kind of worked its way out. So there was a decision made of, if we're not seeing it, why include it in the vaccine? Why take the time, the money, the effort, the risk profile? Just drop it. So we are having H1N1, influenza A H3N2, and a B Victoria strain is going to be the flavors we're getting this season 24-25. This is the classic flu vaccine schedule, 1 dose per year seasonally. Now, if you notice, previously unvaccinated children are advised to get 2 doses 4 weeks apart just for their first time, and then they go on to that 1 seasonal dose for likely the rest of their lives. People ask me on this one, Eric, how good is this vaccine? Well, last year, it was 52 to 67% effective in children and 27 to 79% effective in adults. Now, I like science and I like hard numbers, and those numbers are wide. 27 to 79% is crazy. That's as long as my leg here. Oh, if you could go back, please. The reason is this data is very tough to collect. This is what accounts for that wide variance in what you call, if you could go back to the last slide, please.
Mike, can you go back one?
Thanks. That's what accounts for that variation between 27 to 79%. Are we talking about people who were exposed to influenza and previously vaccinated, and then we tested them to confirm they didn't get it in that 7-day window? Are we talking about people who showed up sick to the emergency department or urgent care with influenza, and they say, hey, were you vaccinated? Well, yeah, it's February, and I got vaccinated in September. So this data is ripe with problems. Okay, and it's difficult to collect this information. So I don't want this to be a hole in the armor of that efficacy of the influenza vaccine, but I also wanted to present this data to the teams. All right, next slide, please. RSV, 2 strains of RSV, A and B. Fortunately, the vaccine covers against both. Children less than 8 months of age get a single dose based on weight. Now, I want to remind everybody again, this virus is the #1 cause of hospitalizations in our infants across the nation. Children 8 to 19 months old, if they have risks, should also receive a single dose. Now, this is where that conversation with your pediatrician is going to come into very important play. Nobody knows your kiddos better than you and your pediatrician, right? Have a conversation with them about if they have a congenital heart disease, or if they have an immune compromised disorder, if they have cystic fibrosis, what comorbidities should be considered to get that second boost or that additional dose of RSV vaccine in that 8 to 19-month-old age group. Now, we talked about how this is bimodally affecting our older adult age group. 60 plus are also looking to receive one single dose. This isn't every year going forward. This is a one and done, one time after the age of 60, kind of like your shingles. I just turned 50 and I got my shingles celebration. Woo, turned 50 vaccine. Yeah, Eric. 60 years and older, we're recommending you get one of these once in your life. Again, because we're seeing that age group, they're getting RSV because that immunity has likely waned over that period of their life, and they're getting sick and they're getting hospitalized. Now, what's cool about this vaccine is vaccinating pregnant women in their 32nd to 36th week of pregnancy gives across the placenta transplacental protection to that infant, which is amazing. So we're working really hard to make sure our OB-GYN doctors, our pregnant moms, our birthing centers, everybody's up to speed and making sure that we're getting these into our pregnant ladies before they deliver, especially going into this season, right? People ask me, Eric, how good does this vaccine work? RSV vaccine in adults 60 and over reduce symptomatic lower respiratory tract infection by 80 to 90%. That's a number.
Dr. McLaughlin,
yes,
one of the
yes,
things that we're asked quite a bit is after somebody's vaccinated, any concern with breastfeeding?
That's a great question, and I would say no. And I would even say encourage it more, because as we know with breastfeeding ladies, what goes into mom can come out in that milk. And we see lots of other vaccines pass out in that body fluid, which happens to be milk for that young child. I think that's great. You know, I'm a huge supporter of breastfeeding. It's hard for the lady, but it's so good for the baby. And breastfeed right straight through all that. Heck yes. Good question.
Okay, thank you for that. We're having a big breastfeeding workshop, and one of the things that's come up quite a bit is vaccines and breastfeeding.
Now, not all vaccines.
Yep.
Let me pause here. But with RSV vaccine, if you've gotten it in the 32nd to 36th week of your pregnancy, baby comes out, baby's day of life number 5, and you're breastfeeding away, do so without any hesitancy on this. All right?
Thank you.
That's wonderful. Yes.
Great.
Now let's look at how good this works in kiddos. RSV vaccine is 90% effective in preventing hospitalization in infants. This virus causes the #1 hospitalization cause of all of our infants nationally, and it's 90% effective in keeping kids out of the hospital. That's good public health sense to me, right there.
Yeah.
Okay?
Good odds.
Next slide, please, and we'll close up, and we'll get Ms. Tomany ready. So, in summing all this up, if we could go to my last slide, it'll be a quick one.
Next slide.
We want to prevent rather than treat, right? That's kind of the hallmark of public health. That is the hallmark of what vaccines do, going all the way back to Dr. Jenner in the 1790s. If we can't prevent you from getting the disease, we want to keep you out of the hospital, and we want to keep you out of the morgue. We want to reduce that severity of disease. We want to reduce death. And we want to reduce spread of that infection so that it's not getting into other new hosts, replicating, and causing a new strain due to a mutation. That's kind of the goal of what we're doing with all these. I'm happy for any other questions. Otherwise, Ms. Tomany is going to step on up and take the rest of the slides. Thank you all for the time to chat today.
Thank you. Great information. Does anybody have any other questions for Dr. McLaughlin before Tomany gets started with her presentation?
All right, so my slides are not nearly as fun or cool as Dr. McLaughlin's because his are science and mine are where we get our vaccines. So I'm going to start here at the county. We have 3 different vaccine funding sources that we use. We have privately funded vaccines, which come from nursings and our billing of insurance when we vaccinate people. We also have public funding for adults ages 19 through I'm going to say 64 because at 64, most people start to qualify for Medicare, and Medicare isn't covered in this. And that is called 317 funding. And then we also have our Vaccine for Children's program, which runs 0 through 18 years old. The difference between the adult funding and the children's funding is there is no cap on our children's funding. Last year, 3 of our clinics used over $50,000 worth of vaccines in our children's clinics. Countywide for our adults, next slide, because this is on there. Countywide for our adults, last year, we only received $36,000 for all 5 of our sites. So the reason I'm leading into this is because Dr. McLaughlin talks so great about all these vaccines and what people need this season coming up. And we wanted to take a stand on what we're going to provide from the county for these vaccines. The numbers on the left-hand side of the screen with all the vaccines that we carry are our regular vaccines. So it's not our seasonal vaccines. It's your one and done every year or boosters as you get older. We used all of our money last year for all of these vaccines. That didn't include the new vaccines, which are COVID, RSV, and the Mpox vaccines. Our flu is separate funding, so that's a little bit different for adults. But we are going to really direct people to use their pharmacies for their COVID and their RSV vaccines this year. We will continue to supply flu. We have set dates that we are going to start pumping out doing flu clinics every Friday and the first week of every month for October, November, and December. We're going to hit it really hard in all of our clinics trying to get our flu out. But as I said, for COVID, we are going to push people to the pharmacies and RSV. Next slide. Our private funding this year, we spent $7,000 around on vaccines, and we brought in almost $9,000. That's a $2,000 gain, which all of us were very, very pleasantly surprised. So we will continue to do that. Next slide, please. Our financial allotment for 2024-2025 has not been defined yet. It comes out usually the 1st of October. We will have some COVID vaccine for uninsured adults or underinsured adults. And we will also have COVID vaccine for underinsured kids, uninsured kids, and access kids. Next slide. All right. So here's the stance that we're going to take since we aren't carrying these vaccines. We're going to do prevention, education, and provide resources for the public to know where they're going to get their vaccines from. The CDC has a great flu campaign that's called Wild to Mild, but it also applies to COVID and RSV as well. The vaccine equity team will help to vaccinate and educate at public functions around the county, handing out flyers to vaccine locations, hand sanitizer, masks for people who are sick so that they can continue to mask clinics and everything like that. We will also continue to keep our list updated of all the places that carry vaccines. Currently, I know in Sierra Vista, we have our big players for our pharmacies, like we talked about, CVS, Walgreens, Walmart, Safeway. We also have our VA clinic and Fort Huachuca for all of our military and retired veterans that they can go to. And we have a couple of little mom and pop pharmacies that are doing it. Be Well is one. It'll do it here in Sierra Vista and Douglas as well. And we will flood our social media with the CDC respiratory illness prevention marketing tools. Next slide. All right. These are some of the things we'll be teaching on. We'll be teaching the importance of immunizations to prevent, our hand hygiene, clean air. Now that it's finally getting a little bit cooler, we can open our windows and get our houses and our offices cleared out a little bit. Treatment if you're diagnosed, and staying home to prevent the spread. The updated guidelines for staying home is 24 hours if you are fever-free without medications and your symptoms are getting better. You do want to take those extra precautions and wear your masks after that, only because some of these viruses tend to shed a little bit longer than and be contagious than we are sick. All right, next slide, please. All right, so those are our sources, but I do want to touch on, Dr. McLaughlin mentioned with the birthing hospitals and everything for RSV. I am continuing to reach out to them. We are trying to get the hospitals to vaccinate our babies within the first 5 days of the RSV vaccine because that is what's recommended by ACIP and the CDC. And we are also reaching out to all of our OBs and asking them to vaccinate moms at 32 to 36 weeks. If mom is vaccinated at that 32 to 36 weeks, the baby does not need to be vaccinated. So the more moms that we can get vaccinated before they deliver, the better off these babies are going to be because those vaccines do cross the placenta barrier. So those are our goals as the clinical services part of the respiratory illness prevention for the year. Any questions?
Thanks, Tomini. Before Axel starts this presentation, I wanted to talk about a reality and how the Board of Health can help. Arizona had more deaths from COVID than heart issues and cancer put together, which is awful. And so we really need your assistance in messaging. It really is about public health policy. We need to get the message out that the vaccines work. They allow for that prevention and protection. And we're really trying to move away from the buzzword COVID because people have a reaction to that and talk about respiratory viruses and getting vaccines against respiratory viruses because we want people to be protected. You know, I know I'm tired of hearing about people passing away when the prevention is available. So we really are trying and working very hard to get the message out. Get vaccinated. Have your loved ones vaccinated. Let's all be protected. You know, it's so important. You know, Arizona being first in deaths relating to COVID is not a badge of honor. We can do better. And so we're going to continue to run campaigns, get the message out, and we're working with young people as well, trying to send out messaging that isn't scary, that's fun, like wild to mild. And so that's where we're headed, is really focusing on the messaging, letting people know where they can get the vaccines, when they can get the vaccines, and they're available for everybody, whether you have insurance or you don't have insurance. So please join me in that messaging because it's so important. We want people to live healthy and well. So with that, I'll pass it over to Axel.
Good morning, everyone. This is Axel, and I'm going to be providing an overview of what the data suggests for Cochise County in terms of infectious diseases. And then afterwards, we're going to have a discussion about where do we stand in the conversation of Mpox and also some COVID-19 updates. Next slide, please. Many times providers and offices reach out to the health department asking for numbers, but many times we're still not to the quarter of the year, and we got to be very careful about how we interpret those numbers. So before we move on to the next slide, which has some data, please remember that these case counts that are going to be provided for this year, 2024, we still have 4 more months to go for this year. So there's that incompleteness for 2024 data. Last year's data, which is 2023, still needs to be reviewed and finalized by the state. And until that time, those will be the official numbers. So for the presentation, we picked the conditions of most interest. And we'll start with those enteric conditions that affect our digestive system. And in this case, it's going to be Campylobacter. We see a big difference with Campylobacter in 2024 compared to 2023. And there's this particular characteristics of the bacteria that causes gastrointestinal distress, that it is very susceptible to changes in weather, such as heat, cold, and also the humidity in the environment. This year, we didn't have as hot as the weather than it was last year, so that might account for some of that variability. The other one to talk about here is salmonellosis, also known as salmonella infection, which is the second circle in the graph. It is generally accepted in the EPI community that up to 30 cases may be out in the community for each one detected. So the burden of disease here might be a little bit underestimated, but this is also because salmonella sometimes causes milder symptoms. Many times during our investigation process, we call up a case and ask, hey, tell me about your symptoms. But many times they either don't have any symptoms or have non-specific symptoms to GI distress. Another category of infectious disease that we want to talk about here is those antibiotic-resistant hospital-acquired infections. For this year, we're at 10 for carbapenem-resistant Enterobacterales, and then last year we were at 9. But if we compare it to a 5-year average from 2018 to 2022, we're about 7 times as high that we would expect. So we're seeing that pattern of increasing antibiotic-resistant bacteria colonizing our patients here in Cochise County. Valley fever, also known as coccidioidomycosis, is at about what we would expect. E. coli, which is the fourth group of bars here, we're a little bit above what we would expect, but this is also due to a small cluster that was identified in the community that very close contact among these 3 cases happened. So that kind of pushed the numbers a little bit higher. Moving forward with Legionella, that is our red arrow in the center. We want to discuss Legionella because this is a highly fatal condition.
And that's Legionnaire's disease, right?
Correct.
Yeah.
Yeah, Legionnaire's disease. So we can get it through inhalation of water that's been standing. And what's important about this slide, we have had 2 this year and 5 last year. But when accounting for the mortality rate for this condition, it gets really close to 60% of those cases ending up passing away. So prevention and early detection for treatment is super important in this case. And then the last one, not everything is bad news. With MRSA, we've seen some improvement towards a lower amount of cases were identified this year than previous years. So that is highly associated to good infection prevention practices and good hand hygiene. So we did discuss a little bit about Campylobacter and how it gets affected by climate patterns, and then Salmonella. Also, this year we have had about half as many outbreaks detected in Arizona. So that is also affecting the decrease in the amount of cases that have been detected, because many times with Salmonella, it is detected here in Cochise County, but also some patients that have been related to this case in Pima County and surrounding counties. So it's like a cluster of cases usually. Okay, next slide, please. Changing gears to the Mpox discussion here in Cochise County. I think it is important to note that we haven't had any cases detected in 2023 nor 2024. We did have 2 of them in 2022. And the nursing department has put in a request for the vaccines. Maybe are going to be provided through AHS, but at this time we have no official response. Although Jynneos is now being pushed to the commercial side pharmacies would probably be able to supply those. And at this time, we have 13 doses at the health department available, which will be expiring pretty soon in September of 2024, by the end of the month.
So what is mpox?
Mpox. It is a cousin of smallpox, in which you get some sort of blisters, pustules in your wrists, in your genital area, and usually around the oral cavity. It is not very deadly. It's about 3%, but the stigma that's associated to having those lesions might have some other consequences, like mental health issues.
So it's primarily transmitted sexually, but it can be transmitted just through body fluids.
Yep.
These pretty ugly blisters that pop and crust over.
Yeah. Looking at mpox from a broader scope now through the state level, they do provide information through their mpox dashboard, and this is where we get the data from. As of right now, we're getting about 1 to 2 or 3 cases of mpox per week. So we're seeing that residual from that big wave back in 2022 still throughout the state. Although about 90% of the cases are accounted for by Maricopa County, Pima County, and Yuma counties. Luckily, Cochise County is at the very bottom with the only 2 cases, along with Apache County. For providers or provider networks, if the etiology is unknown, it is recommended to have a high level of suspicion and test for it anyways. It is sometimes also confused with herpes simplex virus 2, which is your genital herpes, because it causes similar lesions. Also, testing for syphilis, HIV, chlamydia, and gonorrhea is recommended. And the population that appears to be more affected by mpox is males, age 20 to 44, and mostly Hispanic and White males. I'm going to make a pause over there and see if anyone has any questions regarding mpox or the infectious disease trends. Now, with COVID in Cochise County, this is what our epi curve looks like, accounting for the cases per week. So throughout summer, weeks 15 to 25, we saw a very low incidence of COVID cases here in Cochise County, maybe because kids were on vacation, people were spending more time outside throughout the day. And now that kids have gone back to school, well, things are going back to regular. They're having more interaction with one another. They're spending more time inside the house. So that might be a partial explanation on why we're seeing more cases detected in the last 3 weeks, which is lingering about 60 to 80 cases.
Any particular area of the county, or is it widespread?
It's widespread, yeah. And going back to Dr. E's and Tomini's presentation, how do these variants and lineages get named, and what does that mean for everyone out there in the community? Well, I like to compare COVID variants to ice cream.
That's an interesting comparison.
Yes.
I like ice cream better.
I'm glad I don't like ice cream.
So in a way, I like to think about COVID and ice cream together, because there's many different flavors of ice cream, different bases, like your chocolate, your vanilla, your strawberry.
Yep.
But the toppings that you put on these flavors is what makes the difference, the end product. You can put chocolate chip, you can put pretzels, and so on. So and these flavors sometimes come by seasons, like your pumpkin spice coffee. And that's a way that I like to use to explain to myself how COVID is named and how it works in a way.
How it varies during seasons,
Yes,
right?
correct.
Okay.
And there's many different ways that these variants and lineages are named. Like the World Health Organization names it after Greek letters. But then on top of that, we can use the family labeling, which is, well, what family did it came from and where did it originate and how many mutations did it have from its cousin. And we also in the news see very often the variants of concern, which is the highest priority, highest transmissibility, severity. Variant of interest is that variant that is being watched, see how it behaves. And then the under monitoring one is the lowest priority, along with the de-escalated one. Because the de-escalated one either is no longer circulating or no longer causing concerning outcomes with the disease. And so, for my last slide, this phylogenetic tree is what it's called, maps the Arizona samples that have been sequenced starting in 2020 up to 2024. And this is all for Arizona COVID tests that came back positive. And in a way, it helps the community map how those mutations came about, under what lineages do they fall, how closely related they're one to one another, which, in other words, as a common person in the community, this means very little to me, but as a community level, it kind of helps us understand how the variants are behaving, how much they're transmitting one another, and also this helps, in a way, formulate that vaccine, the updated vaccines, the booster shots. We've probably seen the FLIRT acronym in the news. So FLIRT, biologists came out with the acronym because there's amino acid changes as a result of mutations. And so amino acid called phenylalanine got changed for leucine. So that stands for the F and the L. So it's just very geeky changes in naming.
Well, it's easier to pronounce flirt than some of these other words.
And these variants are just a group of variants that are causing concern because of the severity, how much they're being transmitted in the community. And these are, as of right now, the KP, which is a predominant one going around, and the JN is decreasing. And the last one we're going to mention here is the LB1, because we're still trying to identify how it behaves and how much it transmits out there in the community. So that one's being watched. And to conclude my presentation, I just want to thank everyone, and if you have any questions for Dr. E, Tommy, or myself, please put them in the chat or speak them up. Thank you.
Thanks, Axel. Very interesting information. Does anybody have any questions regarding anything that Axel presented?
I just want to make a comment, 'cause
Yeah.
as a private citizen, it's something that I don't know how to grab a concern on it. And it's like, does it matter to me where the virus came from and what it's called? And when you mention all these things, it kind of troubles my mind, because I'm going, well, what am I supposed to do about that? And how does that affect me? And I'm probably more interested in looking at it, but there are a lot of people in the community that go to those slides that we show and they go, well, what is this telling me anyway? And so I don't think it's clear enough the reason that we're showing those. There needs to be a statement of how does it affect you out in the community? You know, because you doctors have your own group of constituents that you look at the concerns, etc. But what we show on our sites for the public should mean something to them, rather than the fact that they need to take a class in order to interpret what you're saying. So you need to be, I think, a little clearer about well, what is happening? And you see what I'm saying? Is if somebody goes to that site, they're curious, but it needs to mean something to them. And a lot of times I've heard of people, they mention to me, well, I go there, but it looks like it's not going up right now. You know, so that's really the concern they have is it spreading right now? How fast is it spreading? You don't need to tell me what it's called or what its mother was or, you know, how it came to be. But can you tell me a little more about how it's going to affect me?
You know, that's a great point. And you know, really this information is for here. When we do our public facing promotional type stuff, we keep it simple, super simple. So we just posted something on rabies because we're seeing an influx in skunks carrying rabies and people are trying to shoo them away and get bit. So we put a graphic with really basic language. What happens when you see an animal behaving oddly? How do you prevent interacting with the animal? What's the treatment if you do get bit? And then we posted something on head lice because we're seeing a lot of parents, these kids are coming home from school with lice. How do you prevent it? What do you do? How do you follow up? And on the flu, we're promoting just really basic, stay protected. On COVID, we're talking about not what it's called, how it came to us, but how do you stay safe? How do you keep from getting, as Dr. McLaughlin says, ending up in the morgue or getting ill? So absolutely, we are posting and promoting basic prevention and taking care of your neighbor. How do you protect your loved ones? The best way to do that is to get a shot in the arm. So that's a really good point. We always try to keep it simple because this stuff gets very complex. It can be very confusing.
Right.
The names are like 24 letters long. And so we want to be mindful of our community.
I think we need to keep promoting the fact that the Cochise County Health Department, I can't speak for other health departments, but that's the reason that we're here.
Yep.
The Cochise County Health Department promotes wellness.
Yes.
And at the top of everything that we're doing, it should be the fact, and we've made it such a political
Yes.
situation, and our board has done that, you know, and so
Yes.
I'm taking credit for that.
Mm-hmm.
Not because it's a good thing, but I'm just saying to you that, you know, you really have to overcome that somehow, because the people that we need to get to, if they're entrenched in one party or the other, it makes it either more difficult to reach them, and we have to recognize that. And I don't know that we need to go out and find out, you know, what their political party is, those that died. But what I'm saying to you is it really makes a difference in how easy it is to get them to have the vaccinations. When the board has made such a big stink out of vaccinations. And that's the reason that the health department exists.
I hear what you're saying, and that's why we're really promoting respiratory care and not using the word COVID, because I think when we say COVID,
Right.
it turns into that political, you know, push and pull.
Right.
So we're really talking about respiratory illness, protect yourself from respiratory illness. And, you know, we started a new marketing campaign, be well, stay well, take care of yourself and your loved ones. Not scary, not governmental overreach, but we care about you. If you care about yourself and your loved ones, you're going to take the steps to get vaccinated. So we're trying to make it about community cares rather than do this or something bad's going to happen. So I hear what you're saying, and we definitely have a large obstacle to overcome. It is hard because it has been so politicized.
Well, and you can't deny that it is political. And so I guess that the health department and those who cherish the things that go on here to keep the public healthy needs to realize who they're voting for.
Yes, voting is a big part of public health policy.
And so that's what I'm saying is, let's forget about, what party you're from, but who are you voting for and how will they feel about public health? Because if we lose our public health, then that's just one more reason that we can't take care of ourselves. Because if I take care of myself, that's one thing. But if my neighbors aren't, that affects me. You see, so it isn't just me, and the public has to realize that,
Yes.
you can't just take care of yourself and say everything's going to be okay. Everybody you touch has to take care of themselves, or we have to help take care of them.
I agree. That's why I am working so hard, as is my team, to really push out good news about Cochise County.
Right.
Constantly, every time something happens that's good in this county, I post it because I want people to know we have the strength, we have the numbers, we want to care for you, we're there for you. The nurses are on right now. They do tons of outreach. Public health emergency preparedness does tons of outreach. We just continue to meet people where we're at, go into the rural areas, go into the communities, the schools, the shelters, the streets, the restaurants, and share our message.
And I have to give credit to the health department. They haven't just wrapped their arms around themselves and said, "Oh, poor me," when all of this negativity regarding the board took place. So I have to give you credit for simply moving forward. And that's what we all have to do when adversity comes, is that you have to move through it. You can't always get around it. You just move through it.
I've told my team and we're small, but we're mighty. And, we stay strong and true to the mission. We have a laser focus. There's always going to be external forces. There's always going to be thunderstorms, but we're here to serve. And we all take that very seriously.
And I think that you should encourage them to look at where the money in Cochise County actually goes and look at that pie chart and realize the mission that they're on and the expenditure that is out of public funds that goes toward your mission is so great that you can't give up.
We won't. I won't.
But they need to understand that each one of them,
Yes.
we're moving forward.
Oh, yes.
And it would be the same thing as giving up the sheriff's department. That's another big expenditure, in Cochise County. And you're almost the same. And they need to understand that.
Oh, we are health and safety, no doubt. We're health and safety, just like law enforcement, just like education, we're health and safety.
Right. So, good job.
Well, we appreciate that. The only other thing I have is workforce development. I continue to focus on workforce development, making sure that jobs are there, getting young people invested, middle school, high school. So back in August, it seems like so long ago, the Center for Change for Arizona, as well as Arizona Complete Health, partnered with me, and we had a big workforce development forum. Over 100 people showed up, and we had another one this month, and that was a result of the first one. We had 4 committees that were developed, and at the end of this month, those 4 committees are going to meet. The first one was on social determinants, so housing, education, food, security, mental health. The second committee is going to be on career pathways. How do we retain people? How do we get them the education, vocational training they need to be successful? Third committee was workforce attraction. How do we get people to Cochise County? And the data was fascinating. We don't have enough people here. We're going to have to attract people to get them here, and we need the revenue here. We're trying to build infrastructure to get people to stay. And then the last one was information and collaboration. How do we get a hub? How do we get, how do we get the information out to people that we're here? So these committees are going to meet at the end of this month, and we are going to develop some action steps to keep this going. I didn't want to just have the forum and everybody talks about great things and there's no action. So these committees are now involved, they're invested. We're going to be meeting on a monthly basis and we're going to start to move the dial. But it's tough. The other thing is I received a grant from the Arizona Foundation, Community Foundation, for $10,000, and I'm using that money to do a campaign on keeping care local. And I'm working with all the hospitals in Cochise County, because if people get their primary care here, the revenue stays here. If the revenue stays here, we build infrastructure. We build infrastructure, they will come. So it's all interconnected. Public health is part of community. It's part of making sure we have goods and services here so we can all thrive. And so it is about connecting the dots. And I have worked very hard to connect the dots and will continue to do that. So that's where we're at with workforce development. We're moving forward. We're trying to get things organized. We're just starting out. But we have tons of investment, and there are a lot of people who want to see things really evolve. And I'm very grateful for that.
Evelyn made some comments about.
Yep. What's that?
I just wanted to acknowledge Evelyn's input in the chat. The first one was that all the agencies here have a common mission, a unified message. So yes, we're with you.
Absolutely.
And then the other input she provided was she wanted to get the contacts for the leads on these 4 work groups.
Evelyn, I'll send that to you. It's on the Department of Health website. We have a really robust group of people for each committee that really want to make a difference. And the committee meeting is going to be September 27th. I'll send you all the information. It's going to be at Cochise College in the Student Union Building in Sierra Vista. And we rotate those. The last one was in Douglas. So I'll send you all the information.
What was that you said on September 27th?
That's going to be the committee meeting. So the 4 committees are going to meet. I'll be there and we'll talk through. We're going to be meeting every other month. And then we're going to have a larger forum where we report out.
Okay. Do we know times or anything yet?
Yeah, I have all that information. I'll send it to everybody on the board.
Okay. Thank you.
You're welcome.
Bye.
So I think the only other thing I have before we close is Axel, do you want to talk about just for a minute some of the unlicensed food vendors we've seen in Cochise County and what's going on with that?
Sure. So throughout the past few weeks, maybe per month, we've been identifying more and more of the unpermitted vendors under the environmental health branch of the health department. And this is happening statewide. We come across these establishments that are unpermitted within county land or within city limits. And it's important to be aware of who we're buying from in a way, have that consumer beware. Just to provide a description of what the food is, fruit cups setting up in the corner of high traffic streets, which that should give you a suggestion that the city probably wouldn't have allowed it because it's creating traffic issues, and then how they're handling the food. So all these conditions build up and increase our chances of getting some sort of foodborne disease because the hygiene is not very good. So if you see something, maybe call in the health department and we'll look into it more in detail.
Yeah, so one of the things we're going to do, you always want to make sure when you buy food, they should have their license displayed. What we're seeing is people often selling meat or tacos or agua fresca, some of the punches. They're not licensed, and then people are coming down with pretty significant gastric diseases because there isn't proper hand washing procedures, the food isn't refrigerated, or it's not cooled properly, or it's exposed to bugs and other things. So what we're going to be doing is we're going to be developing a sticker. It will be bright green, and they will have to show that sticker, and we're going to be doing a campaign around that. So if you go to a food cart and you don't see that bright green sticker, buyer beware. It means they're selling without being licensed. It hasn't been inspected. So we're going to start doing that within the next few months. And we even had a staff member buy something on the side of the street and get really sick, thinking, oh, it smells good, it must be good. But if they're not licensed, it hasn't been inspected. We don't know that that food has been properly stored, or that it's a hygiene, it's not a hygiene situation.
And about the cottage food program expansion, that's going to come into effect once that the final rulemaking takes place. If we visit the state cottage food website, it says at the very top that it's been approved, but not until the final rulemaking happens that it's when it takes effect. So there's more to come on that in the next few months. So we're all waiting for that.
Well, you could see the brouhaha at the legislature.
It's a big deal. It's Smallville, they're calling it. Yeah, it's a big deal.
But I think one thing that we have to recognize is the fact that we are a border county.
Yes.
And many of our people go back and forth into Mexico all the time.
Yes.
And they are very used to buying from street vendors everywhere.
Yes.
Whether it's ice cream or whether it's meat food, whatever, they buy from vendors. I don't know, and I'm speaking out of ignorance, but many times when you have lived in an area all the time, you become not as susceptible to the water or to the bacteria that's there. And so those people are safe. They build up a resistance to it. You walk into it and you have no resistance. And they forget that. So, they're walking with their loved ones and they're all having it, so they have it too.
And we're being, we don't want to be overly regulatory. We're going to be providing people technical assistance and say, okay, we see you have a cart. How can we help you be successful? This is the licensing process. This is, because we don't want to just shut people down and be, we're going to work with them. They're part of our community. But we want to make sure everybody's safe.
Well, they're trying to make a living the
Yep.
only way they know how at that
Yep.
particular moment. And I think it's important for us to try to work with them.
Absolutely.
And some of the regulations are really pretty stringent for someone who's getting started.
Mm-hmm.
And we know that startup businesses have a hard time anyway.
Yes.
And so we add to that by all of these government regulations. And so it makes them want to go around us.
Yeah.
Instead of trying to work with us. So I think it's important to keep that going. It's not going to go away.
Sure.
Food carts are getting to be more and more. Food trucks are getting to be more and more.
Yeah.
So we have to recognize that and try to work with them.
Absolutely. Well, that's all we have for today.
I guess with that, if there's any members, I don't know that I've heard, usually you've had concerns and brought them up, but if there's anything else, Susan?
No, I'm just fine.
Okay, then thank you all for participating, and we'll look forward to the next meeting on December the 6th, 2024. So have a good day. The meeting is adjourned.